Welcome to this session on Applied Behavior Analysis, or ABA, therapy. Over the course of this presentation, we will explore the foundations, history, core principles, and evidence-based applications of ABA within pediatric psychiatry. Whether you are a psychiatrist, a psychologist, a trainee, or an allied health professional, this session is designed to give you the conceptual and practical tools to integrate behavioral thinking into your clinical work. Let's begin by asking the most important question. Why does ABA belong in a pediatric psychiatry conversation? The answer is straightforward. Aggression, self-injury, non-compliance, anxiety-driven avoidance, and social withdrawal are among the most common and most challenging presentations we see in child and adolescent psychiatry. ABA is the most systematically developed science of behavior change, and its applications are rapidly expanding beyond autism into the full spectrum of pediatric mental health. For psychiatrists, understanding ABA improves case formulation, moving us beyond symptom labeling toward understanding why behaviors occur and what maintains them. It enhances collaboration with behavior analysts, school teams, and occupational therapists. And it helps us understand how behavioral contingencies interact with the pharmacological effects of the medications we prescribe. Crucially, ABA does not replace psychiatric care. It provides a precise language and toolkit that works within comprehensive treatment plans. By the end of this session, you will be able to define applied behavior analysis and distinguish it from generic behavior modification. You will describe the historical development of ABA and the 7 dimensions defined by Bear, Wolf, and Risley in 1968. You will explain foundational behavioral principles, including reinforcement, punishment, extinction, stimulus control, and motivating operations. With direct clinical translation, you will identify key ABA assessment and intervention methods used in pediatric psychiatric contexts. You will summarize evidence-based ABA applications across autism, ADHD, feeding disorders, anxiety, and disruptive behavior disorders. And finally, you will discuss the ethical, cultural, and trauma-informed considerations shaping modern ABA practice. Before we go further, let's be precise about what ABA actually is and what it is not, because there is significant misunderstanding in both directions. ABA is a scientific discipline focused on understanding and improving socially significant behavior through the systematic application of behavioral principles. It is data-driven, analytic, and grounded in a century of behavioral science. It focuses on observable behavior and environmental contingencies. It is individualized, context-sensitive, and applicable across settings: clinics, homes, schools, inpatient units, and communities. And it is entirely compatible with pharmacological and psychotherapeutic approaches. What ABA is not, it is not a single program or curriculum. It is not synonymous with rigid compliance training or rote repetition of discrete trials. It is not limited to autism or early childhood, and it is not incompatible with developmental, relational, or humanistic perspectives. Contemporary ABA prioritizes assent, dignity, and person-centered goals. The field has moved decisively away from purely compliance-oriented approaches toward collaborative, values-aligned interventions that respect the child's voice. To understand where ABA comes from, we need to go back to the early 20th century. In 1913, John B. Watson launched the behaviorist movement with his landmark paper, Psychology as the Behaviorist Views It. He rejected introspection as a scientific method and advocated for the exclusive study of observable, measurable behavior. Then, in the 1930s through the 1950s, B.F. Skinner developed operant conditioning through rigorous laboratory experiments. Skinner demonstrated that behavior is shaped by its consequences, establishing the principles of positive and negative reinforcement, punishment, and schedules of reinforcement that underpin modern ABA. By the mid-20th century, researchers began applying operant principles to real-world human problems in education, developmental disabilities, and psychiatric settings. The core logic established by these foundational experiments remains the engine of every ABA intervention used with children today. Systematic manipulation of environmental contingencies can reliably and predictably change behavior. The pivotal intellectual shift that gave birth to ABA as a distinct discipline happened when researchers left the laboratory and moved into classrooms, clinics, and homes. This transition from experimental to applied science demanded fundamentally new methods and criteria for success. Sidney Bijou and his colleagues at the University of Washington were instrumental in this transition, pioneering the application of behavior analysis to early childhood and special education, and training a generation of researchers and clinicians who would define the field. This shift required three things: measuring socially important behaviors, not arbitrary laboratory responses, but behaviors that genuinely mattered to children, families, and society. Designing feasible interventions, procedures that teachers, parents, and clinicians could actually implement in natural environments without specialized equipment, and demonstrating functional relations, showing through experimental control that the intervention, not some other variable, was responsible for the behavior change. The translation from laboratory science to real-world application is what distinguishes ABA from basic behavioral science, and it demanded rigor without sacrificing ecological validity or social relevance. In 1968, Baer, Wolf, and Risley published Some Current Dimensions of Applied Behavior Analysis in the inaugural issue of the Journal of Applied Behavior Analysis. This paper is widely regarded as the formal birth of ABA as a distinct scientific discipline. In a remarkably concise piece, the authors articulated 7 dimensions that continue to shape research design, clinical practice, and professional training more than 5 decades later. They insisted that ABA must target behaviors of genuine social importance, not just behaviors convenient to measure. They required experimental accountability. ABA must demonstrate, not merely assume, functional relations between interventions and behavior change, and they established a shared professional language that distinguishes high-quality applied behavior analysis from other behavioral or psychological approaches. These dimensions continue to guide publication standards, clinical frameworks, and the training and supervision of board-certified behavior analysts worldwide. The 7 dimensions proposed by Baer, Wolf, and Risley serve as both a historical landmark and a practical clinical checklist. First, applied. Interventions must target behaviors of genuine social importance, not behaviors selected for experimental convenience. Second, behavioral. The focus is on observable, measurable behavior, not inferred traits or diagnoses. Third, analytic. A functional relation between the intervention and behavior change must be demonstrated through experimental control. Fourth, technological. Procedures must be described with sufficient precision that any trained clinician can replicate them. Fifth, conceptually systematic. Interventions must be grounded in established behavioral principles, not an eclectic bag of tricks. Sixth, effective. Interventions must produce meaningful, clinically significant change. And seventh, generalizable. Change must maintain over time and generalize across settings, people, and related behaviors. Together, these dimensions define what high-quality ABA looks like in practice. Reinforcement is the most fundamental and clinically powerful principle in ABA, and understanding it is essential for both designing effective interventions and avoiding common clinical errors. Positive reinforcement occurs when a stimulus is added following a behavior and the behavior's future probability increases. This includes praise, access to preferred activities, tokens, or sensory stimulation. It is the cornerstone of skill acquisition and replacement behavior training. Critically, the reinforcer must be identified individually. What reinforces one child may be aversive or completely neutral to another. Preference assessments are a standard ABA tool for this purpose. Negative reinforcement occurs when a stimulus is removed following a behavior increasing its future probability. This is especially relevant in pediatric psychiatry, when a child engages in escape behavior, avoidance of school, medical procedures, or difficult tasks. The removal of the aversive demand reinforces the avoidance. This inadvertently maintains and strengthens the very behavior we want to reduce. But negative reinforcement also has therapeutic applications. Teaching a child to appropriately request a break removes the demand while reinforcing functional communication rather than challenging behavior. And one critical clarification: negative reinforcement is not punishment. Both positive and negative reinforcement increase behavior. They differ only in whether a stimulus is added or removed. Moving to procedures that decrease behavior, punishment and extinction. Positive punishment involves adding an aversive stimulus following a behavior, decreasing its future probability. Modern ABA applies positive punishment sparingly, only when reinforcement-based strategies have been exhausted, and always with robust ethical review. Negative punishment involves removing a valued stimulus following a behavior. Examples include time out from positive reinforcement or response costs such as loss of tokens. These procedures are more commonly used in pediatric psychiatric settings and are considered less intrusive when implemented with proper safeguards. Extinction involves withholding the reinforcement that previously maintained a challenging behavior. It is most effective and most ethical when combined with differential reinforcement, simultaneously reinforcing an alternative, incompatible, or other behavior to give the child a functional pathway to reinforcement. A critical clinical caution: when extinction is first implemented, behavior often temporarily increases in frequency, intensity, or duration before declining. This extinction burst is predictable and well documented. Clinicians and caregivers must be prepared with clear safety plans in place, particularly for children with histories of severe self-injury or aggression. An inconsistent application of extinction can paradoxically strengthen the very behavior being targeted by placing it on an intermittent reinforcement schedule. Stimulus control refers to a pattern in which a behavior occurs reliably in the presence of a specific antecedent stimulus, because that stimulus has historically been associated with reinforcement. A child may follow instructions from one teacher but not another. This reflects differential stimulus control that can be systematically shaped through consistent contingencies. Discrimination training teaches children to respond differently across different stimuli or contexts. This is foundational for safety, social, and academic skills. Distinguishing stop from go signals, recognizing safe versus unsafe adults, adapting communication to different social partners. But the ultimate clinical goal is generalization, ensuring that skills learned in a therapy room occur across the child's natural environments, with different people, in different settings, with varied materials. A BA explicitly programs for generalization using strategies such as teaching in multiple settings from the outset, using stimuli present in the natural environment during training, involving multiple trainers, including parents and teachers, training loosely with varied examples and using natural reinforcement contingencies rather than only contrived ones. Generalization failure is one of the most common reasons behavioral gains are not maintained after treatment. Proactive planning is essential, not an afterthought. Among the most clinically powerful and most underappreciated concepts in ABA for pediatric psychiatry are motivating operations and setting events. These concepts explain why the same child in the same classroom may respond very differently on different days. An establishing operation is an event that increases the reinforcing value of a stimulus and increases behaviors that have historically produced it. The classic example is hunger. Food deprivation increases the value of food as a reinforcer and increases food-seeking behavior. In clinical settings, establishing operations may include sleep deprivation, medication changes, or social isolation. An abolishing operation does the opposite. It decreases the reinforcing value of a stimulus and decreases related behaviors. Satiation is the classic example. Clinically, identifying abolishing operations helps explain why a previously effective reinforcer suddenly stops working. Setting events are broader contextual factors: poor sleep, medication adjustments, family conflict, sensory overload, or acute medical illness that do not directly trigger behavior but alter the probability of behavioral responses to subsequent stimuli. These are especially critical in pediatric psychiatry, where biological and psychosocial variables constantly interact with behavioral contingencies. Identifying motivating operations transforms behavioral assessment. Rather than asking only what triggered this behavior, we ask, what was different about the child's state or context today that made this behavior more likely? This reframing improves both assessment accuracy and intervention planning. These four procedural tools form the technical backbone of ABA skill acquisition, the mechanisms by which children learn complex, multi-step behaviors that would otherwise be outside their current repertoire. Shaping involves reinforcing successive approximations toward a target behavior, starting from what the child can currently do. Each step closer to the target earns reinforcement. Previously reinforced approximations are placed on extinction as criteria advance. Chaining breaks complex behaviors into discrete steps and teaches them in sequence. Forward chaining teaches the first step first. Backward chaining teaches the last step first, giving immediate success. And total task teaches all steps every trial. Applications include dressing, toothbrushing, multi-step coping routines, and emergency safety procedures. Prompting uses external supports, gestural, verbal, visual, model, or physical prompts to evoke correct responding when the child cannot yet perform independently. Prompt type is selected based on the child's learning history and the least intrusive level that produces correct responding, and fading systematically reduces prompt intensity and frequency over time to promote independent responding. Without planned fading, children may become prompt dependent, performing the skill only when a prompt is present. Fading ensures that stimulus control transfers from the prompt to the natural cue in the environment. ABA's defining commitment to continuous, objective data is what distinguishes it from most other clinical approaches. It enables the precision necessary for evidence-based decision-making in complex pediatric cases. The common behavioral measures include frequency and rate, how often a behavior occurs per unit time, ideal for discrete behaviors with a clear onset and offset. Duration, how long a behavior lasts, essential when the concern is persistence rather than count. Latency, time elapsed from instruction or prompt to initiation of the target response, key for measuring compliance and task initiation in ADHD and oppositional presentations. An interval recording, coding presence or absence of behavior within defined time intervals, allowing efficient observation of high rate or continuous behaviors in classroom and inpatient settings. Data are graphed continuously and analyzed visually, examining level, trend, and variability across baseline and intervention phases. This approach allows clinicians to determine objectively whether an intervention is producing the desired change. Identify when a plateau has been reached. Detect unexpected increases in challenging behavior. Make timely decisions to intensify or modify treatment, and provide transparent database communication to families, schools, and interdisciplinary teams. Visual analysis, not statistical significance testing, is the primary analytic tool in ABA, reflecting the field's emphasis on clinically meaningful rather than merely statistically detectable change. The Functional Behavior Assessment, or FBA, is the cornerstone of modern ABA assessment. It is a systematic process for identifying the function, or purpose, that a challenging behavior serves for the individual child. Function-based interventions consistently outperform interventions selected without functional information and reduce reliance on generic, punitive, or trial and error approaches. There are 3 levels of FBA. Indirect assessment uses structured interviews with caregivers, teachers, and the child, standardized rating scales, and review of records and prior behavior plans. It is efficient but limited by informant bias. Descriptive assessment involves direct, systematic observation of the child in natural settings, recording antecedents, behaviors, and consequences. It identifies patterns in real-world context without manipulating contingencies. Experimental functional analysis involves systematic, controlled manipulation of antecedents and consequences across standardized conditions to test specific hypotheses about behavioral function. It is the gold standard but requires trained personnel and safety planning. The 4 most common behavioral functions identified through FBA in pediatric psychiatric populations are: attention. Behavior produces social contact or engagement, escape or avoidance. Behavior removes or delays aversive demands, access to tangibles. Behavior produces access to preferred items or activities, and automatic or sensory. Behavior is maintained by its own sensory consequences, independent of social mediation. A high-quality behavior. Intervention Plan is a comprehensive, individualized document that translates FBA findings into a coordinated intervention strategy. BIPs developed without a functional foundation are substantially less effective and risk reinforcing the very behaviors they target through inadvertent attention or inconsistent application. A complete BIP includes 5 components. First, operational definitions. Precise, observable descriptions of target behaviors that allow any implementer to identify the behavior consistently. Second, functional hypotheses. Clear statements of what antecedents precede the behavior and what consequences maintain it, derived directly from FBA data. Third, antecedent strategies. Proactive modifications that reduce the likelihood of challenging behavior before it occurs, such as adjusting task demands, embedding choice, modifying the environment, and pre-teaching coping strategies. Fourth, replacement skill teaching, explicitly teaching functionally equivalent alternative behaviors that serve the same function as the challenging behavior but are socially acceptable. This is the most durable component of effective BIPs. And fifth, consequence strategies and crisis procedures, differential reinforcement protocols, planned ignoring, and where warranted, response cost, alongside explicit crisis and safety procedures for severe aggression, self-injury, or elopement. BIPs integrate naturally with medication plans, psychotherapy, and school accommodations. AB, skill acquisition programs in pediatric psychiatry target a broad range of domains. Communication, including verbal language, augmentative and alternative communication systems, and functional communication training. Social skills, turn-taking, joint attention, perspective taking, emotion recognition, and peer interaction. Daily living, hygiene, dressing, feeding, and domestic routines, critical for independence and family quality of life, executive functioning, task initiation, organization, transition flexibility and self-monitoring, and coping and emotional regulation, identifying internal states, using coping tools, and tolerating frustration. Instructional formats are matched to the child's needs. Discrete trial teaching uses highly structured, massed practice learning trials with a clear antecedent response consequence format. It is optimal for initial skill acquisition when the child requires intensive repetition and controlled stimulus presentation, and most effective when combined with naturalistic teaching for generalization. Naturalistic or incidental teaching embeds teaching opportunities within play and daily routines, capitalizing on child-initiated interactions and natural reinforcement. It promotes spontaneous language, generalization, and motivation. And naturalistic developmental behavioral interventions, frameworks such as JASPER, the Early Start Denver model, and pivotal response treatment, integrate ABA principles with developmental science, emphasizing child interests, social engagement, and naturalistic contexts. ABA's methodological signature is the single case experimental design, a rigorous approach that allows clinicians to establish functional relations between specific interventions and behavior change at the level of the individual child without requiring large group samples. This is particularly powerful in pediatric psychiatry, where heterogeneity across patients makes group-level findings difficult to apply to individual cases. The three primary single-case designs are the AB-AB reversal, moving from baseline to intervention to return to baseline to reinstated intervention, the multiple baseline design, which staggers intervention introduction across behaviors, settings, or people, and the alternating treatments design, which rapidly compares conditions. These designs are evaluated through visual analysis of graphed data, examining changes in level, trend, and variability across phases. They provide a rigorous, individualized evidence standard especially well suited to the complex presentations seen in pediatric psychiatric practice, and allow clinicians to experimentally test whether a specific intervention rather than maturation or concurrent treatment is responsible for observed change. ABA is the most extensively researched intervention for autism spectrum disorder. Early intensive behavioral intervention, typically 20 to 40 hours per week of structured ABA for children under age 5, has the strongest evidence base, with multiple randomized controlled trials and systematic reviews documenting significant gains in IQ, language, adaptive behavior, and academic readiness for many children. In the area of communication and language, ABA interventions, including verbal behavior approaches, augmentative and alternative communication systems, and functional communication training, represent the most evidence-dense applications in ASD. FCT replaces challenging behavior maintained by communication deficits with socially appropriate alternatives. For social engagement and play, naturalistic developmental behavioral interventions, such as the Early Start Denver model, JASPER, and pivotal response treatment, embed ABA principles within naturalistic social and play contexts, targeting joint attention, social reciprocity, and flexible play skills while preserving child motivation and dignity. And in the domain of adaptive functioning, ABA programs targeting daily living skills, self-care, and community participation reduce caregiver burden, improve family quality of life, and support successful transitions across educational and community settings. Beyond ASD, ABA principles have demonstrated clinical utility across a wide range of pediatric psychiatric presentations. In ADHD, token economies, response cost, and differential reinforcement are evidence-based behavioral strategies for increasing on-task behavior and reducing disruptive responding. Parent training in behavioral management, Teaching consistent contingencies, clear expectations, and home-based reinforcement systems is recommended as first-line or adjunctive treatment in younger children and complements stimulant and non-stimulant medications. In anxiety and OCD, ABA conceptualizes these conditions through the lens of escape and avoidance contingencies. Rituals and avoidance are negatively reinforced by short-term anxiety reduction. Exposure-based procedures with response prevention, blocking compulsions to allow anxiety to habituate, align directly with ABA extinction principles and underpin evidence-based CBT for pediatric, OCD, and anxiety disorders. In disruptive behavior disorders, function-based interventions using differential reinforcement, non-contingent reinforcement, and antecedent modifications reduce reliance on seclusion, restraint, and PRN medications in inpatient and residential settings. And in feeding disorders, food refusal and selectivity, maintained by escape from eating or sensory consequences, respond well to ABA-based feeding programs using escape extinction, systematic shaping, stimulus fading, and differential reinforcement, reducing medical risk and caregiver stress significantly. In inpatient psychiatry, unit-wide token economies, level systems, and individualized behavior intervention plans for severe aggression or self-injury reduce critical incidents and restrictive procedures. In schools, ABA-trained clinicians conduct functional behavior assessments and develop behavior intervention plans that support individualized education programs and crisis prevention, with direct interface to psychiatric medication timing and side effect monitoring. Thank you for joining this session on applied behavior analysis in pediatric psychiatry. The principles and methods covered here provide a powerful complement to psychiatric care, grounding our clinical decisions in behavioral science, data, and a deep respect for the children and families we serve.